So we are going to discuss about treatment and prognosis of membranous nephropathy. So in patients with primary membranous nephropathy, this is membranous nephropathy who present with normal kidney function and do not have severe disabling or life-threatening nephrotic syndrome, we treat only with general supportive measures. So general supportive measures including RAS inhibition only for 3 to 6 months, and we monitor for signs of disease progression. So how do we monitor for signs of disease progression? So we use these parameters: 24-hour urine protein excretion, serum creatinine with determination of glomerular filtration rate, and serum albumin at baseline and every 1 to 3 months depending on the clinical severity of presentation. If the patient has PLA2 receptor primary membranous nephropathy, that is serum anti-PLA2 receptor antibody positive or positive immunostaining for PLA2 receptor on kidney biopsy, so we monitor those patients with serum anti-PLA2 receptor antibody titers by ELISA to evaluate the immunological activity of the disease. We typically monitor antibody levels every 2 to 3 months and consider more frequent monitoring in patients with high antibody levels, arbitrarily defined as greater than 150 unit per ml. After 3 to 6 months of observation period or sooner, if the patient has signs or symptoms of rapid disease progression, we stratify patients into following categories of risk based upon an assessment of the temporal trends of these clinical and serological parameters. So we stratify into following categories: high risk, moderate risk, and low risk. So in high risk groups, patients with 2 or more of the following considered to be at high risk of progressive disease. So among these three, there is 2 or more of following, then it is those patients are considered to be at high risk of progressive disease, like decrease in EGFR 25% or more, not explained by other causes any time during the observation period, proteinuria more than 8 gram per day at the end of the observation period, or persistent nephrotic syndrome. And third is, if the patient is anti-PLA2 antibody receptor positive, serial anti-PLA2 receptor antibody titers are high and not declining or are increasing to greater than 150 unit per ml. Such patients are high risk, and such patients should be treated with immunosuppressive agents without further delay unless otherwise contraindicated. And which patients are at moderate risk of progressive disease? So if patient has 2 or more of following these 3, then those patients are considered to be at moderate risk, like normal or stable. Stable means less than 25% decrease in EGFR over the 3 to 6 month observation period. If proteinuria persistently between 4 and 8 gram per day, here it was above 8 gram per day, here it is in moderate risk, between 4 and 8 gram per day at end of the observation period. If patient is anti-PLA2 receptor antibody positive, serial anti-PLA2 receptor antibody titers are less than 150 unit per ml and stable or increasing by less than 25% over the 6 month period. Here it was greater than 150 unit per ml, okay, and not declining, or are increasing to greater than 150, it is high risk. But if the titers are less than 150 and stable or increasing by less than 25% over the 6 month period, such patients are considered to be at moderate risk of progressive disease. And such patients, do you start treatment or not on patients with moderate risk? So patients at moderate risk of progression may or may not require treatment, may require treatment, may not require treatment with immunosuppressive therapy. Our approach to initial therapy varies depending on the course of the disease during the initial 3 to 6 month observation period. And which patients are considered to be at low risk of progressive disease? So patients with 2 or more of following are considered to be at low risk for progressive disease. So normal or stable EGFR less than 25% decrease over the 3 to 6 month period, proteinuria less than 4 gram per day at end of the observation period. If patient is PLA2 receptor antibody positive, serial anti-PLA2 receptor antibody titers are low or decreasing by 25% or more at 3 to 6 months. So patients with low risk of progressive disease do not require immunosuppressive therapy and can be managed with general supportive measures only. In general, we do not give immunosuppressive therapy to patients if they have evidence of severe and irreversible kidney damage, that is history of CKD or serum creatinine greater than 3.5 or EGFR less than 30 for greater than 3 months, kidney size less than 8 cm on kidney ultrasonography, or evidence of severe interstitial fibrosis, tubular atrophy, or glomerulosclerosis on kidney biopsy. Since immunosuppressive therapy is not likely to be effective in such patients. Okay, in general, three parameters evolve in concert. Three parameters means one is proteinuria, EGFR, and anti-PLA2 receptor antibody. So these three parameters evolve in concert with changes in anti-PLA2 receptor antibody levels, typically predicting changes in the clinical parameters. So this antibody level predicts the changes in the three clinical parameters. Okay, in this paradigm, if this paradigm does not apply, like say decline in EGFR is accompanied by decline in this antibody titer, then alternative causes should be excluded first, like superimposed disease, hemodynamic effects of RAS inhibitors, and renal vein thrombosis. Okay, so these should be excluded first. And now we are going to discuss what is the importance of this anti-PLA2 receptor antibody levels in treatment modality. Okay, so we'll start with the clinical scenario. So 60-year-old patient with newly diagnosed membranous nephropathy and nephrotic syndrome presents with proteinuria of 7 gram per day, and his creatinine is 1, albumin is 2.5, mild to moderate peripheral edema is present. The patient receives general supportive measures including RAS inhibition over a 6-month observation period, and over the course of 6 months, proteinuria does not change appreciably. Let's say from 7 to 5 and then again 8 gram per day, and creatinine remains relatively stable and serum albumin remains stable. So in which settings where we should start immunosuppressive in this patient? So here comes the importance of anti-PLA2 receptor antibody. So let's say if anti-PLA2 receptor antibody is persistently high, at baseline serum PLA2 receptor antibody level is 250, at 3 and 6 month anti-PLA2 receptor antibody is 270 and 250. Okay, so it is persistently high during the 6-month observation period. In this scenario, we would initiate immunosuppressive therapy based upon the combination of persistent nephrotic syndrome and persistently high anti-PLA2 receptor antibody levels. Let's suppose anti-PLA2 receptor antibody is increasing. At baseline serum anti-PLA2 receptor antibody level is 70. At 3 and 6 months, the anti-PLA2 receptor antibody level increases to 130 and 200 respectively, let's say. So in this scenario, we will initiate immunosuppressive therapy based upon the combination of persistent nephrotic syndrome and progressively rising anti-PLA2 receptor antibody titers. So in what settings we would not start immunosuppressives and we just treat expectantly? So in anti-PLA2 receptor antibody are low and in decreasing trend. Okay, so in those conditions we would treat expectantly with general supportive measures only. Progressively decreasing anti-PLA2 receptor antibody levels suggest that the patient may achieve a spontaneous clinical remission. Okay, anti-PLA2 receptor antibody high but in decreasing trend. Let's say at baseline serum anti-PLA2 receptor antibody is 250. At 3 and 6 months, anti-PLA2 receptor antibody is 30 and 80. So you can see it is in decreasing trend. Okay, so in this scenario, we would not initiate immunosuppressive therapy but continue to monitor closely. Okay, monthly monitoring. Okay, so choice of initial therapy is decided based upon the risk, whether patient has high risk, moderate risk, or low risk. Okay, so high or very high risk of progression of disease. In the choice of immunosuppressive therapy depends on how the patient is defined as high risk or very high risk. In patients who are classified as high or very high risk because of abnormal or declining kidney function at presentation or rapidly declining kidney function due to membranous nephropathy, we suggest combination treatment with glucocorticoids and cytotoxic agent. And among cytotoxic agents, cyclophosphamide is preferred rather than rituximab or other therapies. And in patients who wish to avoid cytotoxic therapy, treatment with rituximab may be reasonable alternative. In addition, patients with membranous nephropathy who experience a rapid decline in their renal function test should be evaluated for other potential causes of worsening kidney function such as crescentic glomerulonephritis, acute hypersensitivity interstitial nephritis, or acute bilateral renal vein thrombosis. So in patients who are classified as high or very high risk and have a stable kidney function, we suggest treatment with rituximab rather than cytotoxic therapy or other therapies. We prefer rituximab to calcineurin inhibitor because of the more prolonged remission with rituximab and higher relapse rate of calcineurin inhibitors after therapy has been discontinued. Okay. However, either a calcineurin inhibitor or a combination therapy with glucocorticoids plus cytotoxic agent is a reasonable alternative to rituximab in patients who are PLA2 receptor antibody negative. Now we are going to discuss about moderate risk of progression, and last we will discuss at low risk of progression. Okay, so in low risk of progression do not require immunosuppressive therapy and can be managed with observation and general supportive measures only. Such patients generally have excellent long-term prognosis and often undergo a spontaneous or complete remission. But in moderate risk of patients, who are at moderate risk of progression, our approach to initial therapy varies depending on the course of the disease during the initial 3 to 6 month observation period, with maximal general supportive measures including RAS inhibition. Okay. In moderate risk patients who show progressive increase in proteinuria over the observation period, we recommend treatment with immunosuppressive therapy and continued general supportive measures rather than continued general supportive measures alone. Okay, so we recommend treatment with immunosuppressive agent if there is progressive increase in proteinuria over the observation period, and this is common sense. Okay, in moderate risk patients who show stable proteinuria over the observation period, we suggest immunosuppressive therapy and continued general supportive measures rather than continued general supportive measures alone. Okay, in moderate risk patients who show progressive decline in proteinuria over the observation period, we withhold immunosuppression. Okay, and continue only general supportive measures. In most moderate risk patients who require immunosuppressive therapy, we suggest rituximab rather than glucocorticoids plus cytotoxic therapy or calcineurin inhibitor. So we prefer rituximab over glucocorticoids plus cytotoxic therapy or calcineurin inhibitor. Okay, if rituximab is unavailable, either combination therapy with glucocorticoids plus cytotoxic agent or a calcineurin inhibitor monotherapy is reasonable alternative. Okay, and if cytotoxic therapy is chosen, we prefer cyclophosphamide over chlorambucil since chlorambucil has more side effects. If a calcineurin inhibitor is selected, either cyclosporin or tacrolimus is reasonable choice. Okay.